Thanks, Brendan. I want to thank Mark Rollins for asking me or making sure that I got on the docket today. Mark and I have worked in CMQCC task force for hemorrhage for several years. And while we're getting set up here, the work that we have done and the knowledge that we have gained about simulation and obstetrics would not be possible with the support of the administrative team, folks like Dr. Maury Drusen, Dr. Sheila Cohen, Dr. Ed Riley, who saw the potential in us doing simulation and made sure that it was supported, as well as the people who actually worked with the team, Steve Littman, Kay Daniels, myself, and our clinical nurse specialist, Andrea Puck. So, and from the nursing administration, everyone saw the potential in this and allowed us some headway to get started. So what I want to talk to you about today are what are some practical things, thank you so much, that we can do to make our drills more effective. And Steve asked us, or Steve kind of pointed out in his talk a little bit about what drills can do. So I want to just kind of expand on what he presented and maybe, hopefully, if all the planets are lined up, show you a little bit of video about what that can look like. I have no disclosures for you. The learning objectives for this presentation are to talk to you a little bit about components, not leaving anything out of a drill, and then how you can use drills to get staff engaged in what you want them to do, and also how you can generate information about your place of practice using drills. So the first tip I have is you really need to think about the topic of your drill, and it should be a topic that is exquisitely relevant to the people you're training. And you can look at maybe there's an educational gap, or maybe there's been difficulty implementing a policy with high reliability. You've got this policy, it looks great, but it just never seems to work out right when you actually have to use it. Maybe there's a persistent problem that you see on the unit, or the nurses see on the unit, or there's a new policy and procedure. You may have had a sentinel event, or potentially a QI data stream that's telling you there's a problem on the unit. I would share that information with the people I'm training. Hey, the reason why we're running this drill is because we have huge infection rates in our OR. Or the reason why we're running this drill is we had this event that occurred and we didn't turn out so well. So we want our response to be better the next time we face this situation. Using the actual patient data, changing up a little bit is fine. I think that is more relevant. People can, sometimes people in simulation will tell you, well, this would never happen. Well, guess what? This was a case. This happened to us. This is why we're simulating. So a few examples that I have listed for you that may be relevant to your practice in OB and as an anesthesiologist. Emergency intubation of the pregnant woman is always something that can be an issue. Implementation of a new policy like massive transfusion, and hopefully I will show you a small snippet of what we learned when we implemented the massive transfusion policy at Stanford, at Packard, Lucille Packard Children's Hospital. So just several different kinds of topics. Another one that I'm becoming more and more interested in is first responder training. How do you get first responders in the room? That's the nursing staff you're dealing with. How do they organize themselves? How many do you need? How many stay in the room? What should they be doing? How can you make it simple? You can't expend all of your education dollars on something that hopefully will never happen on your unit, yet you have to have a staff that's always ready to respond. So it's quite a push and pull. My second tip would be consistency, particularly if you're looking to train an entire staff, an entire unit. You want there to be some consistency with what you're doing. And in order to have that consistency, I like using a template, something that captures all the information you need to faithfully run that drill anytime you need to run it. And I'm going to pull out learning objectives and metric data collection. If this looks like you've never seen this before and you are part of the simulation faculty for your hospital, I would suggest you go to a simulation instructor program. Simulation training is very different than what we have traditionally done in healthcare. We've traditionally done a testing to see how much do you know. We want you to get 100 on this test. We're going to run some skills. We want you to do the skills perfectly. Simulation is a 180-degree twist where we're looking to see where the issues are. Where do we have gaps? How can we fill those gaps? So it's a little bit of a different way of training. So learning objectives should guide everything you do, from who you're training, how you're training, the mannequin you're using, how many people are in the room, do you need actors, do you not need actors? So learning objectives are the key. And we spend a lot of time with cognitive and technical in healthcare. We're very good at giving people information, articles to read. This is everything you need to know about maternal cardiac arrest. These are the technical skills you need to complete a maternal cardiac arrest. What we spend less time on are the behavioral skills. What kind of communication skills do you need? What is the organization of the room that you need? How do you bring the team back into focus if the room gets chaotic? And for some of us in a code, it's not if the room gets chaotic, but when the room gets chaotic. So thinking about the team skills, thinking about team building and team management. It's best if the learning objectives are measurable. Any of you who have ever tried to debrief a simulation know that it can be a daunting task. The more measurable your learning objectives are, the more you can engage the people who were in that simulation in a productive discussion about the learning objective and whether it was met or not met. What I learned from training with some of the debriefers from NASA is that when they debrief, they know that their people are pretty well, the astronauts are pretty well cognitive and technically strong. They've got a good fund of knowledge and they're pretty technically savvy. So when they find breaks in performance, it's typically a behavioral issue. So I'll give you an example. Most of us know that when you're starting two-person CPR, it's a 30-to-2, right? Your patient's not intubated, you're going to do 30 compressions to 2 ventilations. If that doesn't happen, it's probably not that they don't know that, and it's probably not that they can't do that. There's something else there. There weren't enough people in the room. The noise level was too loud. They were confused about their role. All of those things are behavioral. So if something isn't occurring, getting to the why of it is very helpful for teams, particularly to improve performance the next time. This is why I think measurable learning objectives are hugely important, as well as a small number, and I'll talk about that later in a minute. I would say learning objectives covering all three, cognitive, technical, and behavioral, no more than 3 to 6 for each discipline is adequate. So giving you just a few examples of cognitive, technical, and behavioral learning objectives that are measurable. Less is better. There is an impulse when you're writing a drill to put everything in it that could potentially happen. And please avoid that impulse because it becomes a large drill. Sometimes the trainees can get lost in it. And what I would recommend, if you've got a series of things that have to be covered in a drill, so let's say you want to run a drill on preeclampsia and you want them to respond to an eclamptic seizure and also know how to handle MAG toxicity, that you break that up into 2 separate drills. Make them short drills that people can get in, get invested in, learn from, break out, and then debrief. It's a lot easier to debrief a 5 to 7 minute drill than it is a 30-minute drill. It takes a long time to get through 30 minutes of activity. For those of you who came to our workshop on Thursday, there wasn't a scenario we ran that was over 7 minutes, and we had ample topic to talk about. So you can really get through a lot of good information with the shorter amount of time devoted to the drill. Lastly, I want to talk to you about metrics and reporting. I think the days when we have money just to train people are probably dwindling. I don't know if you feel the same way, but more and more hospitals are asking us to do more with less. So if you have a budget for training and you can actually learn something about your system and make improvements in your system while you're training, it's going to be even more beneficial to your hospital, and it's going to be even better received when you ask for more money or additional time to do more training. So when I talk about metrics, I'm talking about some type of data collection measurement, whether it's based on learning objectives, known performance issues, systems issues, problems with the hospital being able to support you when you want to implement a policy, or maybe it's a process to determine best practice. So one example of a metric is a time metric. How long does it take for something to occur? As Steve suggested, calling that drill on the unit and finding out how long does it take people to get there. That's really important because when you plan training for first responders, you can give them an idea. You're going to be here 3 minutes. You're going to be here 5 minutes. You're going to be here hopefully no longer than 5 minutes. But if it is, that's a long time for first responders to have to work on that patient until the code team gets there. But knowing that information can guide your training. It will guide your drill. You may look at time based on medication. When is the medication asked for, and when is it appropriately given? If that is too long of a time frame, there could be a system problem there. Looking at process. Some people can easily figure out the best way to do anything. Those are the kind of people you want to observe on video in a drill. Because if you can emulate what they're doing or come up with a standardized way of how they're performing, you may increase the efficiency of the entire unit just by sharing that information. So when we run drills, we video record just about every single thing we do. And if we see something that's really stellar, we like to take that video and really analyze it to see what was so stellar about that, and is there something with that performance that we can talk to the rest of the unit about. First responder goals. We're spending a lot of time working on this now, but it's been my experience that if you give people goals they have to reach, they will reach them for you. So one of the things that we tell our first responders in labor and delivery when they come for training is from the minute you confirm pulselessness, we want you to be on the chest within 10 to 60 seconds. So we want you to begin effective compressions 10 to 60 seconds. From the time you confirm pulselessness till the time the first shock, we want that to be about 2 minutes. That's a very short period of time. And the nurses sometimes will look at me and go, I don't know how we're going to do that. I'm like, you know what? I don't know how we're going to do that either, but if you all put your head together, you're going to figure out how to do it. You're going to figure out how this is going to work for you with your specific set of circumstances in your unit. One of the examples that I would give you that actually resulted in a publication was location of perimortem delivery. And I've got the reference down. I know this article's been mentioned several times. But that came out of, some of that came out of the work that we did in simulation. So once you've completed your drills, it's time to analyze your findings. And your findings will come from a variety of different areas. You may have findings from just measuring performance of your learning objectives. How many times did they know something versus how many times did they not know? Maybe a policy or procedure. Things will happen in debriefing. and people will come up with great near-miss information that needs to be fed right back into the system. And I cannot count even on two hands the number of times I have pulled a nurse up at the end of debriefing and said, you know what, we are going to go right down and talk to patient safety right now because we need to get this into the system. This is a huge issue for our hospital. We march right down and put a report in and people start working on it. So that's the kind of information you need to capture. Those are the metrics that I'm talking about. What changes did you implement? Sometimes in the midst of running a series of drills, you find something that's so important, you have to change it immediately. One of the first things that we looked at is why we didn't have ambu bags in every labor room. We had 3 on the unit. We couldn't wait till the end of the series of drills to change that, so that changed immediately. What recommendations do you have to change in the future? If you found a near miss, and it's not something that can be easily changed at that point in time, who needs to be involved, and you can make recommendations to that to administration. And then it also informs you what else you need to do. You may run a drill and find that, you know what, we are really, really good at responding to OB hemorrhage, but one of the things that we are really our problem is getting the blood down from the blood bank to our patients. How are we going to streamline that process? So you may want to drill something like that in the future to see what is going to be the best answer to that problem. So there is a cycle that you can utilize in a drill, and it's a quality improvement cycle, just as Steve alluded to. You pick the right topic for the drill based on data. You write observable, measurable information into that drill that you can actually evaluate process, evaluate time, sometimes evaluate performance, although we don't particularly say this particular person did this or didn't do this. We would say of the 89 nurses that we looked at, 40 of them were able to do adequate chest compressions, that type of a metric, performance metric. Conduct the drills, look at the data, analyze the data, and that informs your next series of training. So I included just a few references that I think are helpful, and my email if that is helpful, and thank you very much. Now, this is a video, and my husband and I last night were desperately trying to load these videos into this presentation. We were wishing we had a 10-year-old to help us because we were sure that would have helped. So I'm going to give this a little bit of time to load up because that was the only way we could get it in there. They're a little bit large. But these are video recordings that were put together by Kay Daniels of just a fraction of the things that we learned in some of the early simulation drills that we ran on the labor and delivery unit. This first one has to do with emergency transportation. And one of the things that I think is hugely insightful about video recording is you get to see what you really look like, not what you think you look like in your head, which sometimes is a little bit different. So this first recording is the work that was done very early on to try to figure out what actually is the best way to get our patients from the labor room to the OR. It's a silent movie for at least a portion. Wait. Okay, let's bring this layout down. But you have the IV that's on there. Take this off.
The IV is off or disconnected? Marilyn, make the door shut and keep it open here, okay?
Okay, just the IV. We don't need the rest of it.
Okay, Sally, out of the way. Let's get her on the gurney.
Okay, come on, right along there.
This was not a super stat, but we were trying to get back there as fast as we could.
On your side, sweetie. Come on. Over to your side. Here, let that be over on her side. We've got her on her side. What's going on here? We've got a knee back with heart counts down. She's Andrea's patient. Andrea's at lunch.
Okay, let's bring the side rail up. Side rail up. How long has it been down?
It's been down for about 2 minutes.
And I think if you're honest, you'll probably see some of these things have happened to you. This is a separate set of drills.
We did not do left uterine displacement. We did not do it backward, and we're about to get out of it.
It's funny and horrifying at the same time, isn't it? The reason why we have this angle is because the IV lines are wrapped around the bed. So some changes were made. So we started eliminating the gurney because we got new beds, and the beds now fit through the doors.
You're going to ORA.
Literally, and anyone who works in our unit can tell you this, the process literally changed dramatically. People who weren't even involved in drills were coming up to the nurse manager saying, "What have you guys been doing? This has changed so for the better." So one more, if you'll humor me with one more. Actually, let me go back. Okay, this is a very old one, but in this situation going into it, the nurses in labor and delivery were always in trouble because they had so many overrides on the Pyxis. And in reality, when I would stand up at conferences and I would say, "Do you ever wonder what happens to the nurse when you send her off to, or him off to get uterotonic agents?" Obstetricians and midwives and providers everywhere would go, "Oh, I know." They always agreed with me. So we decided to put a video camera in the Pyxis room. This is what we found. Whoops.
this is our problem here. This is what I was talking about. Remove.
And the nurses had actually been complaining about this to no avail. This is a very important topic to them.
There's no methogen, so we might get the right meds.
So this nurse has been sent to get a series of uterotonics for a patient who's actively bleeding.
Excuse me.
Methogen, and I'll give you the fake methogen.
Come on. Come on.
It's comical in this setting. It's heartbreaking in an actual case, which is why the Pyxis overrides were so prevalent.
This isn't even reading my finger now.
So we don't actually take drugs out of the Pyxis, so you're going to see someone standing behind this nurse who's going to trade out drugs so the drugs don't actually leave the Pyxis.
And some oxytocin. Come on.
So we found several problems with the machine and with the process, and we gave administration a number. 2 minutes, 750 mLs a minute, you do the math. That's too much blood. So they changed stuff for us. This is with the improved process. This nurse is getting the same drugs out of the same machine. And then just hit cancel.
Okay.
Are you getting the kit?
Yeah.
There you go.
All right.
So these are the corrections. And at the end, you give administration a metric. We went down to 29 seconds. That's a metric. That is what helps to engage your staff in a drill, that type of improvement in workflow. That's what invests quality improvement in your drills, because we all know we have no money, but we know who does. Risk management has money, and quality improvement sometimes have money, patient safety. So those are the people that you can get to with this type of data.